The following podcast hosts trainees from Latin America, Laura Saavedra from Venezuela, Andres Gomez and Perla Colunga from Mexico, Rafaela Muratori from Brazil, and Susy Bazan from Peru. The podcast is divided into two parts. In the first one, they will present current facts and realities of transplant, cellular therapy, and education in their respective country. In the second one, we discuss shared experiences and challenges. But most of the time, we will listen to them and learn from them. That's it. Enjoy.
My name is Rafaela. I'm a pediatric bone marrow transplant fellow from Curitiba, Brazil. I'd like to thank the Trainee Committee for inviting me here today. And I'm going to talk a little about bone marrow transplant and cellular therapy here in my country. So this is a very challenging thing to do because we do have a lot of different realities between states and regions. We currently have 116 centers and 184 transplant teams, but most of them are located in southern Brazil and in capitals. There are 20 fellowship programs with 39 fellows per year, but only one of these programs are located in the northeast of the country. So right here we see our first big problem, that is distance and accessibility. We know that we cannot perform all the transplant demands that are needed in our country, and we do have patients relapsing while waiting for transplant. We can see here how we have fewer teams and numbers compared to developed countries. But we do have a strong and united community that started in 1979 with the first bone marrow transplant from Latin America performed by Dr. Ricardo Paschini and Dr. Euripides Ferreira. And our community is led by our Brazilian Society for Cellular Therapy and Bone Marrow Transplant. We do have a lot of meetings, regional, annual journals, written consensus, a variety of working parties. We do have a partnership with a lot of international societies and transplant registry partner with LABMT with 62 participating centers. And when we talk about numbers, we were approaching 4,000 transplants before COVID, and with almost 30% of this transplant reported to the Brazilian registry. And this allowed us to know and see our results as a whole, not just the number of transplants, but the outcomes, the complications, the kind of transplants, the demographic of these patients. And we can see here that the haploidentical transplant with post-transplantation cyclophosphamide is growing exponentially and allowed us to increase donor availability and increase the number of transplants. When we do talk about the difficulties, it's important to understand that even though we are a upper middle income country, around a quarter of the Brazilian population, around 52.7 million people, are poor or extremely poor. And we also have our own tropical and endemic diseases. We have to consider the living conditions of these patients. So to where we start discharging these patients, can he or his caretaker understand the prescription and follow and come to checkups? So this is a lot of things that we have to understand about our populations during transplant. Also, 75 of our bone marrow transplant are funded by public health care. So we do have interference from politics and government. Sometimes the healthcare is not a priority, sometimes it is. So this changes and it impacts positive or negative. We do have overworked and underpaid staff and specialty nurses that need to handle too many patients at a time. We have limited access to certain drugs. In some cases, we have no access at all. Not only drugs, but technologies, and sometimes not only drugs for commissioning, but viral treatment, graft versus host disease also. And a lot of this trouble we do have is because of importation. So economics and inflation are a problem here because we do import a lot of technology, a lot of drugs, a lot of material. So the prices change a lot because of inflation. Also, when we approach the cellular therapy era, these difficulties, they will be much more explicit, as we do know that this technology, it's very expensive. Of course, CAR T cells can improve survival rates here in Brazil. We do have a couple of centers performing it, but it's very expensive. One way we think we can overcome this is develop of cellular therapy in academics like universities, and partnering the government and public and private funding for this technology. We are partnered with the FACT, the Foundation for Accreditation of Cellular Therapy. So we are accrediting a lot of centers. So in the next years, in the years to come, we can start doing it. And also we sure will need international collaboration and training because we are behind this therapy because of its costs. But from where I see it, we were able to achieve so much, and I'm very proud to be part of it. Of course, our problems will remain for a while, but Brazilians, and I believe all Latin Americans, we have this amazing determination to fight and to overcome our obstacles. So here I brought an example of severe combined immunodeficiency patients. This is our data, and as we know, transplant forest kit patients have worse outcomes after they are more than 3.5 months old, or they do have active infection at the time of the transplant. So even though these patients are referred here very late for a bone marrow transplant, and almost all of them are very much older and infected at a time, we managed to succeed and achieve such good survival rates. So it's an example how we can acknowledge our difficulties and learn to overcome them. So it's essential that we keep growing and learning through experience and collaboration. And I say this especially because I'm a pediatrics fellow and we do have a lot of rare diseases. So it's essential that we collaborate to understand our diseases and manage them. And I'd like to thank my team, my attendings. I'd like to thank especially Dr. Carmen Bonfim, that is my mentor, Dr. Ricardo Paschini, that is a pioneer and living proof that of what we can achieve if we put our minds to it. And also a big thank you to Dr. Fernando, our society president, who will kindly lend me his data to this presentation. And finally say that I'm very excited to this talk so we can think of ways to improve care for this patient here in Brazil and Latin America. So thank you very much.
Hello, my name is Andrés Gómez from Universidad Autónoma de Nuevo León in Monterrey, Mexico. And I am here with my colleague, Dr. Perla Colunga, to talk about the hematopoietic stem cell transplant training experience in Mexico. There is a very low number of hematopoietic stem cell transplants performed in Mexico in comparison to those performed in the United States or in Europe and Asia. Overall, regarding Latin America, we are also unfortunately a country that does not do a lot of stem cell transplants, around 40 procedures per 10 million inhabitants, which is a very, very low number. In Mexico, there are around 50 transplant centers around the country. Half of them are private healthcare facilities who only treat either patients with private insurance who pay for the policies from their own pocket or who can afford the high costs of private care. The remaining 25 centers are responsible for the care of the rest of the population. That means that 2/3 of the patients in the country are publicly insured or have the governmental insurance, and 1/3 of the patients are not insured and should either pay for the procedure out of pocket or be treated in centers that treat uninsured patients. So most centers around the country perform few procedures. Around 30 procedures per year is a high number for our centers. Regarding hematopoietic stem cell training programs, since there are a few centers that do the procedure in our country, there are also few centers that perform training in transplants or a fellowship as a whole. Around 5 to 10 transplant training programs are available. Most of them do not report their outcomes to international registries or are engaged in academic activities. There is only one FACT-JC created unit, which is our own, and there are only 1 or 2 spots in BMT training programs per year available to either adult or pediatric hematologists. So most procedures performed in Mexico are autologous transplants. Regarding allogeneic transplants, most are done using peripheral blood. Few, if any, umbilical cord blood transplants are performed. There is a low number of unrelated donor use due to the costs and the reimbursement and the availability and regulatory issues associated with this donor type. However, haploidentical transplantation, as in the rest of the region, is up and coming. There is no CAR T cell availability in our country yet.
About the trainee experience, we believe that they are exposed to few procedures and that we support a high responsibility and burden. Of course, there is not enough nurses, pharmacists, residents, or attendings, and there is a limited scholarship opportunities for national and international rotations. Some ideas for the future to improve the transplant education in Mexico include strengthening communication between local transplant centers. As we are few hematologists, we believe that it would be desirable to receive transplant training, a collaboration with high-income countries and low and middle-income countries, and the development of online tools and social networking. We hope that this information has been useful to describe the situation of the transplant training in Mexico. Thank you very much for your attention.
Hi, I'm Laura Saavedra from Venezuela. I am an internal medicine specialist and hematologist graduated in December 2020. I work as an attending physician at the Hematology Department and Bone Marrow Transplant Center Dr. Abraham Somoza in Valencia, Venezuela. Before I move forward, I would like to thank the EBMT Trainee Committee for the opportunity to share with all of you our experience in bone marrow transplant and training. To begin with, you must know that in Venezuela there are 2 bone marrow transplant centers. One is in Caracas. It's a private clinic that treats children and adults as well. and the other one is here in Valencia, where children and adults are treated. We perform autologous, haploidentical, and matched-related donor transplants. However, we do not perform umbilical cord or match-unrelated donor transplants because Venezuela is not part of the international bone marrow banks. In our team, there is a doctor in charge of adult transplant patients, and the other one is in charge of pediatric transplant patients. I have to work with both types of patients, but in general, we are all capable of treating children and adults as well. Now, talking about transplant education during hematology residency, in Venezuela, there are 5 hematology residency programs that last 3 years, and education for transplant therapy is given during the 3rd year. 2 of those programs are in Caracas, and those residents do their rotation at the Caracas Transplant Center. The other program is here in Valencia, where I did my internship, and the residents trained in this program rotate for 4 months at the transplant center. During that time, they receive theoretical education about the different types of transplant, management of acute and chronic complications, etc. And the classes are taught by the doctors in charge of the transplant center. The residents have the opportunity to put that knowledge into practice because they are in close contact with the patients in our center, from the moment of admission until the patient's discharge. The residents from other programs, despite not receiving any theoretical education for transplant therapy, come to Valencia for a 4 weeks rotation at our center. But that's basically all the training they receive. And last but not least, the residents from the 5th program do not have any type of theoretical or practical training in transplant therapy. For the fellow hematologists that would like to train in transplant therapy, there is an internship program at the Caracas Transplant Center, but currently there are no trainees at that program. Because of the pandemic, last year, all rotations at the transplant center were suspended, except for mine. I was the only resident rotating last year, so I could dedicate myself throughout the complete year to work with many patients as possible with different conditions and handle all kinds of acute and chronic complications. So, I would say that my training as a resident last year was unique because no other resident had the privilege to work a whole year at the transplant center. And now to talk about cellular therapy, well, that's something that is not available in Latin America, so I don't have any practical experience in that field. However, as a resident, I received some theoretical education about that topic. Well, I hope I have clarified some doubts about the way we work and train in Venezuela, and let you know that despite these challenging times, we are still doing our best to keep offering transplant therapy to our patients. And once more, I would like to thank the EBMT Trainee Committee for this invitation and hope that we can continue working and collaborating together in the future. Bye!
Hello, everybody. My name is Susy Bazan. I am a hematologist. I work at Cayetano Hospital in Piura. I did my hematologist training at the Revalidati Hospital for 4 years. Then I worked for 3 months at the National Children Institute. So today I'm going to talk about Peru bone marrow transplantation situation. About demographic data, Peru's population is 33,035,304. And we have an increase of 17.7 times the populations since 1836 until the present. Here we can see in this pyramid population that we have more older people and less newborns. Nowadays, we confront a transplantation need of 200 bone marrow transplants per year. About the poverty in my country, before COVID era, we have 6.6 million of Peruvians were in poverty, which represents 17.3% of the population, and 2.9% were in extreme poverty. Nowadays, we estimate that poverty will increase to 9.9 million of Peruvians, and also the 94.7% of poverty population have an informal job. Here, about the density of health workers, we can see that there is an unequal geographic distribution of health workers. Lima and the coastal areas for the capital have the highest densities. Here we can see in Callao and only Lima, and we have less health workers in other cities like Piura, Loreto. So I have to mention that we come with only 10 centers that treat oncohematology disease. There is poor access to this service, and many patients are referred to the capital to receive treatment. Considering that the waiting time to receive treatment is long, and we do not have access to the latest technologies. For Peruvian health system, we can see that Peru has decentralized healthcare system administered by 5 entities. One of them is Ministry of Health, which represents 60% of the population. Social service, secure service, which represents Salud, which represents or covers the 30% of the population, and the Armed Force, FAAA, the National Police, PMP, and the private sector, which provide health service to the remaining 10%. So with a fragmented system, equal and quality access is not guaranteed to all Peruvians. Here we can see that health centers accredit for hematopoietic cells transplant in Peru. The only centers that perform identical transplants are Ricardo Revalletti Hospital and the National Children's Health Institute of San Borja, as well as match sibling donor transplant. And also, this transplant is performed in San Borja Clinic, that is a private service, and the National Neoplastic Institute. So 43% correspond to Social Security Center, 28.5% correspond to Ministry Health Centers, and the last 28.5% correspond to the private practice centers. I have to mention the average cost for autologous transplant is about 100,000 pence. Match sibling donor is about 180,000 pence, and identical is about 240,000 pence. So patients who require transplant with an unrelated donor are sent abroad Peru to have this option. Here we have the rate per million of bone marrow transplant in COVID era is 4.6. It's 4.6. So in this recent data, we can see that the major of transplant performed Ricardo Revalletti Hospital and Neoplastic National Institute. So there are 4 public hematopoietic cell transplant centers and 2 private centers. All of them were affected during the COVID pandemic, as well as throughout the world. Peru has no exception, no? We can see the decrease in the number of transplant patients, that we get a total of 282, and now we have 155. Also, I have to mention that we have a national registry of potential and related donor hematopoietic stem cell, which called REC-CPH, is from Ministry of Health, and is not yet operate, and there are still no process to define for the initiation of unrelated transplantation. Now about hematology training. Before pandemic, before COVID era, we get hematology residency, 7 in MINSA, in Ministry of Health, 10 in Salud, and 3 in Armed Force Centers. Fellowship in pediatric hematology become 1 in Salud. This fellowship is since 2015. Now, during pandemic, we have a decrease of this hematology residency. We only have 9 in MINSA, fellowship in pediatric hematology, 3 in MINSA 2. And about bone marrow training in Peru, first we have to study in medicine school for 6 years. Then we have to study 1 year internship, to do internship for about 1 year, and to do a serums, that is a rural service, for 1 year. Then we postulate to residency program that is about 3 or 4 years to study. It depends on the university we postulate. And if we want to do a training of bone marrow transplant, we have to do it abroad Peru. We do not have formal training in bone marrow transplant. Well, it's all I have to make about my country. It's a hard reality that we have to face. Thank you very much.